Okay, so more about new drugs for inhalation and new devices. This talk will be maybe a little bit of something old, something new, and mostly something new. This is part 3, so I'm not going to repeat what we did in parts 1 and 2, but there will be some things that I will repeat so that it is consistent with the flow. So the objectives here are to compare nebulizers, pressurized meter dose inhalers, soft mist inhalers, and dry powder inhalers, to state the nebulizers used for specific formulations, to discuss important factors in selection of a specific aerosol device for an individual patient, use the GOLD and GINA guidelines to determine appropriate inhaled drugs for COPD and asthma, and to discuss the role of inhaled drugs for systemic delivery. So I'll point out a couple of drugs that are now administered by inhalation with the intent of getting it into the bloodstream and having a systemic effect, something that we try to avoid with drugs like bronchodilators. So today we have lots of different aerosol generators that we can use, different types of nebulizers, the Respimat soft mist inhaler, which is becoming increasingly popular, pressurized meter dose inhalers with spacers and valve holding chambers, and there are some new ones. One that I think was just released onto the market in the last month or so, and dry powder inhalers, which have become increasingly popular, and a lot of the new drugs that are coming out for COPD and asthma management are as powders rather than.
So are they as costly as the meter dose inhalers?
Some of them are more costly. They are very expensive.
That's what I thought.
Yeah, the cost of the pressurized meter dose inhalers is going to be coming down because there are generics that are now coming onto the market because patents are running out after 20 years. But the dry powders, so the meter dose inhalers are going to become less expensive. The dry powder inhalers are very expensive, but the rub is that some of the best drugs for management of COPD and asthma are only available as a dry powder. There's no other alternative. But it can be a big issue for people with COPD, for example, most of whom are retired, they're on fixed incomes, and this can chew up a lot of their income.
Yep.
So nebulizers, there are a number of different jet nebulizers that can be powered either from wall oxygen or with a compressor. Ultrasonic nebulizers, there are a number of these that are now commercially available that are handheld devices, and some of these are quite popular among patients at home. For example, they don't require a compressor, they're battery operated, and there are probably the newest of the nebulizers are the mesh nebulizers like the Aerogen, but not just the Aerogen, but also the Pari eFlow device and the Omron device. This is pretty popular for use by patients at home, and the device which is used, the INEB device, which is used to deliver the Tavis pulmonary vasodilator. And I think some of these we talked about in a lot more detail last time I was here, so I'm not going to go through
but
all
those
of that
four
detail
are all
again.
with specific drugs.
So the Aerogen,
Well, they're excluding
that can be used for any drug, and in fact,
but the four below it.
This is the one that you know that goes in line with the ventilator circuit, but it can also be used with a chamber now that patients can use at home. This is also an Aerogen that can be used at home. The eFlow is all with specific drugs. There's not a generic version of that. The INEB, specific drug, Ventavis. And the Omron can be used with any drug. This can be used commonly used with bronchodilators by patients at home. So the options for patients at home are typically the Omron mesh, or one of the ultrasonic devices, or a jet nebulizer with a compressor. And the jet nebulizer with the compressor is probably the least favorable for patients at home because it's not very portable. You need to plug it into an electrical source. These are battery operated and they're smaller. And some of these can be actually operated even off of the the DC adapter in the car.
But the jet nebulizers are still the least expensive approach for patients.
Correct. A jet nebulizer compressor combo is probably $40.
Right.
So
Yeah.
that's the least expensive.
CVS, yeah.
This on-run device, I think, is around $100-ish. I haven't looked up the cost recently, but it's more expensive. And of course, the other big question is what are covered by insurance and by Medicare, and that's, yeah, I don't know the answer to that. But it really becomes an issue for us taking care of these patients when patients could be using any number of one of these devices. And it becomes an issue with patients because not all drugs are available in a solution that can be placed into one of these devices. So a patient ends up with multiple devices, which adds not only expense but confusion. So we talked about this in some detail the last time I was here about the importance of driving gas flow and fill volume with jet nebulizers. So the typical jet nebulizer, there are some exceptions to this rule, but the typical off-the-shelf jet nebulizer works best at a fill volume of about 4 to 5 milliliters and a flow of 6 to 8 liters per minute. So why might that be an issue? Well, some unit doses are not provided as 4 to 5 mLs. So an albuterol unit dose is 3 mLs. On the other hand, other drugs like Toby, the vials, I think they're still 5 mLs. So they are actually designed to be used correctly with the jet nebulizer. Why is the 6 to 8 liters per minute an issue? Well, it can be an issue if the patient's compressor at home is not working very well. And there is now some evidence, I think I shared some of that the last time I was here, is that compressor performance deteriorates over time. So if there's a COPD patient who keeps being admitted for exacerbations, I think an appropriate question would be, how old is your compressor? Can you bring it in? Let's take a look at it. Let's make sure it's working, because I personally had the experience where you look at the patient's compressor, they bring it in, and you turn it on, and it goes pop, 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 and it's hardly generating any flow at all. And then this is what we're talking.
One question about
Yes.
What do you use now as the percent of the drug that makes it into the lung with the small volume nebulizer?
Yeah, about 10 to 20%. So
With the small volume.
with the small volume nebulizer. Yeah, a lot of it is lost during exhalation
Absolutely.
into the room.
But that's even a higher percentage than I would have thought.
Yeah, and it's variable. And there's a lot of it that's lost in the dead volume of the nebulizer.
Right.
So that's why the fill volume of 4 to 5 mLs is important. Most jet nebulizers have a dead volume of about 1 milliliter. So it's about a milliliter of the drug that never gets aerosolized. So if you only put 2 milliliters of drug into the nebulizer, half of it is wasted. If you put in a 3 ml vial of albuterol, a third of it is wasted. And for bronchodilators, it might not matter that much. They're dirt cheap, so you could just put in a second vial if you don't get the effect with the first one. So this is something we were talking about before we got started with the lecture, which is the title of the paper was Reliability of Vibrating Mesh Technology, but maybe the title should have been On Reliability of Vibrating Mesh Nebulizer.
They didn't mention this last week.
So this is a study we published in Respiratory Care a couple of weeks ago by Jerry Smaldone and the group from Stony Brook, where they took a bunch of brand new Aerogen vibrating mesh nebulizers, and they found that it was not uncommon that some of them would just stop. So here it's filled. This one works great. All the liquid is gone. This one stopped. Just stopped when halfway through the dose delivered.
So what we found out, the reason for that is air bubbles on the surface. It appears.
Yeah,
Especially
so
with the continuous.
maybe, I don't know, maybe those are, I don't know if those are air bubbles there, but
Because you can actually take that device, have it working, turn it so you get all the fluid off the mesh, and then turn it back up slowly, and it won't work. Click it, and it works again.
This is for continuous.
shouldn't be that difficult.
It shouldn't be that difficult. I agree.
Yeah. Right. So, but I mean, I hear reports from here. I've heard it from people elsewhere in my travels. And a common question that respiratory therapists are asking around the country is, do you know of problems with the aerogen just stopping? Well, you know, it's reported in the literature. It's just something that we should be aware
So
of
on
with
that
these
problem
devices.
with the air, it's, so does one air bubble just change the whole harmonics of the thing, or because you don't get a I don't know what scenario you get a whole complete bubble of air under there. I've never seen
It
it.
doesn't have to be a huge bubble. It doesn't even have to be nothing that you can actually see easily. But you can demonstrate it happening.
Yeah, you see it all
And
the
you
time.
can
They're flicking
create-
it.
And you can create the bubble you can create the phenomenon by having the feed line on a continuous, having air bubbles in it, and it'll be work fine until that air bubble hits the nebulizer, and it'll stop.
So another issue with the mesh nebulizers that is not commonly appreciated is that if you get moisture under the mesh, it won't work. That's why they get placed on the dry side of the humidifier.
Yep.
So if you put it on the wet side of the humidifier and you get humidity under the mesh, it stops. It fouls the system. And then there have recently been a number of drug mesh nebulizer combinations that have become commercially available. And these use the PARI eFlow device. So this is also a mesh nebulizer. And there is some debate about who first engineered the mesh, whether it was PARI or whether it was Aerogen. And a few years back, they were working that out in the courts. But the PARI eFlow is also a mesh nebulizer. And what the PARI folks have done is they have partnered with various drug manufacturers to make the mesh specific for delivery of individual drugs. So in this case, the mesh nebulizer is paired with Astrionam, which is an antibiotic used instead of Toby in some patients with cystic fibrosis. So here the drug delivery, the device and the drug have been paired together. And typically what happens is the patient gets the drug and 28 days of medication in a box from a specialty pharmacy.
And we see patients who come in with that, but it's really a small number.
Correct. So,
Very small number.
so Toby is the first line,
Right.
but some patients are intolerant of Toby, and then this is used as an alternative.
Or they're resistant organisms.
And this is much correct. Resistant organisms or intolerance. This is, I think, much more expensive than Toby. Toby is now available as a generic, as you know. So this is a more expensive alternative. And then just within the last 6 months, another mesh nebulizer became available to deliver Arikase, which is for the use of treatment of Mycobacterium avium complex or MAC infections. Again, mostly in the CF population. So the target for this drug is in patients with CF who develop MAC. Now, here is the rub. So if the patient is on Astrionam and they're also on Arikase, they have one of these for their Astrionam and they have one of these for their Arikase.
They're spending about $500 a month or more.
That plus how often do you think the Astrionam ends up in here in the Aero case since I've been here. And the devices are actually engineered, the mesh is engineered to be used with this specific formulation.
Are they very different in their viscosity? That would make it.
Yeah, I don't know. I don't know.
That would be the only big factor that would
Yeah, yeah.
determine a big difference in the output.
Right, right. But it's even known with jet nebulizers is that the formulation can affect the output of the nebulizer.
No question.
So it makes it, I think some of these things make it very confusing for patients. Certainly very confusing for me. And then this device became available within the last 6 months. Again, this is an eFlow device. In this case, paired with glycopyrrolate, which is a long-acting muscarinic antagonist, an anticholinergic. The target for this drug is COPD management. So this is CF, and this is for patients with COPD. And how this works is that the drug comes in a vial. The vial fits in a special way into the device, and then when it's clicked into place, it opens the vial and delivers the dose.
I mean, it looks like a modified Perineb.
It is a modified Perineb. So this is a Perineb, which is modified, the mesh is modified to deliver glycopyrrolate.
That's nice. That's a nice design.
It's a nice design, but an expensive design.
I bet.
And you know, what about the, so somebody, just a few weeks ago, I got an email from somebody and they said, do you think it would be possible to just take the ampule, the vial of the glycopyrrolate, the Lunhala, and just break it open or cut it open and dump it into a jet nebulizer?
Yeah, like you can use,
I said I would recommend
you
that.
can use the reusable Keurigs at home instead of buying a Keurig.
Yeah, there you go. So the issue is that this is a 1 milliliter vial. So right away, that's going to create a problem unless you top up your jet nebulizer. But, you know, all bets are off if you do that. I have no idea how the delivery would work with a jet nebulizer. But there is another solution, no pun intended, which is this drug. I'll let you pronounce it. I haven't worked on the pronunciation yet.
I have no idea.
This just came on the market within the last month or so. This is a once daily. I think this is a twice daily. Oh no, this is once daily as well. But this is a once daily long-acting muscarinic antagonist that is designed to be used in any standard jet nebulizer. So then a patient would be able to use this with the jet nebulizer that they might use for their albuterol, for their budesonide, for other medications. So I think this is going to really make it difficult to market this drug, I suspect. This is also interesting because one of the things that I had heard over the years is that increasingly the FDA is requiring new formulations that come onto the market to be marketed as a drug-device combination.
Right.
But here is an exception to that rule. So
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 this
the
could,
FDA has made that a requirement? Did they do that on their own? Or was that pushed by manufacturers?
well, they're the
I'm
ones who
sure they got help in
regulated.
thinking through that.
Because that's a big part of the problem.
Yeah. Well, but some would argue another part of the problem is that the output of jet nebulizers is very variable, and some are better than others. And
But a generic mesh that works.
Correct.
would be-
Yeah. So your point is a good one. So you could, you could certainly take this medication and put it into, put it into this device, which is a generic mesh. So I found it very interesting that this is sort of like back to the old days where there is a drug that is available that you can use in any nebulizer.
You say it's about a month it's been out.
I saw the first ad for it about a month ago.
I have not seen any orders for it. Have you seen?
Yeah, no, I haven't either.
Yeah, this should probably be used primarily in patients at home, so long-acting muscarinics are probably not used as much in hospitalized patients, more
Agreed, but what if
short-acting.
somebody is, on it, gets
Correct.
admitted?
Right, and
We
one
wanna
of the
continue.
things, one of the things that's recommended, like in the GOLD guidelines and elsewhere, is that before these patients go home, their home medication regimen should be initiated in a hospital.
Right.
I think that probably doesn't happen very often, but that's ideally what should happen.
So we probably put that in Perrynet, right?
Yeah, I mean, you could use a Perrynet, but this, or you
You
could
could.
use a regular jet.
Oh,
You can use any nebulizer you want.
Okay.
Yeah.
But a Perrynet is more efficient, so I would choose the Perrynet.
Yeah,
If they're breathing spontaneously.
the Perineb, Perineb compressor combination is actually very popular in home care.
But I mean, here in the hospital, to use a Perrynet instead of a
Yeah.
regular standard jet nebulizer.
Yep. Yeah. It's more efficient, it
Right.
would be. And this is kind of a segue, right? Your question was kind of a nice segue. So there are now a number of nebulizers that are approved for specific drug formulations, including the PARI nebulizer for Toby, and also to is one of the nebulizers approved for Pulmazine.
We have that one.
Pardon?
We have that Hudson T updraft too.
Yeah, I don't know. what
It's
you're-
the Hudson one we use, I think.
Is the updraft. Right.
Or that we use it for.
Used to use the
Aerosol.
Misty Neb, but might not anymore.
This one's for Aerosol,
Oh, okay.
large volume.
Oh, that one. Yes. I know what you mean. So it's not approved. Abelset is not approved to be used with that nebulizer, but that's the nebulizer that was used in the studies. Inhaled Abelset is not approved by the FDA for inhalation. So. But in the studies, they used large volume Hudson nebulizer. And I think I showed this slide the last time. It might have been the last slide I showed the last time. And Bob said you can take off this bag. So Bob, I did. But I think I might have had a few
Unfortunately,
others.
we have not had a patient, on a spag for 5 years.
I don't think
At
you.
least.
Can we throw that stuff
I don't
out?
think you can.
That's what I want to do. Everybody fights with me when I say throw it out.
But if you throw it out, the problem goes away because I don't think you can get it anymore. I don't
Right.
think ICN supplies it anymore.
Yeah, I mean, I don't even think we've had an order that we've had to fight with for years. I mean, a lot of times we had to fight with people about it, but now I don't even think
Yeah,
that
so-
arises.
So I know one of the things that helped in Upper Lunder about a year before I retired was that the nursing staff really got on this and worked with the docs to have it transition to non-inhalation formulation. So I think the hospital policy now is that the inhaled ribavirin is not a first line. I think it got moved down to like second or
Yeah, it
third
got
line.
moved down, but still, I mean, what I
But
always
there's-
get concerned
So it's still
about.
in the formula?
Yeah, the patient on the ventilator who is
Yeah,
doing really bad and they want to do it.
yeah. So what some places have done, and there are no clinical studies, but there is at least one bench study that has looked at this, is they use the Aerogen. I believe that might be what they do across town, and the reason I say that is that the paper, that the bench study was done by Brian Walsh when he was at Children's. So if you get an order for the ventilator, it might be considered.
I can see a lot of
Then you can just have somebody go by and tap it every so
Correct.
crystallization occurring around that nebulizer.
Tap it.
So at any rate, so this slide got a lot longer over the last 5 years, but now we also know that there's at least one new formulation that can be used with any nebulizer. So maybe we will begin to see some more of that. Okay, let's talk a little bit about the Respimat small mist inhaler. which is, I think, less than 10 years on the market. It has not come out too long ago. This device has a cartridge which includes the drug. There is a spring so that when you turn the base, it puts compression on the spring. There is a dosing chamber and a dose release button. So the idea is then that you turn the base, it puts pressure on the cartridge, you then push the dose release button, and the spring then pushes the drug out of the device to the patient. So this needs no propellant, like an emitter dose inhaler, needs no compressor, needs no electricity, no batteries. It has a dose counter to keep track of the doses, and I think overall is relatively easy to use.
So it has to come though with a specific drug.
Correct. You
So
cannot
loaded.
fill your own cartridges. So, and I'll show you in a minute the drugs that it comes with. Used to only come with one, but now it comes with a number. In fact, I'll show you right now,
Okay.
since you ask. So these are the drugs that it comes with. This one you can ignore because it's only available in Europe. It's not available in the United States. Probably the two most common are Combivent and Spiriva. It currently does not have a commercially available adapter to fit in a ventilator circuit. My understanding is that there are several companies that are working on that, so that might happen in the future. And then it also has the long-acting beta agonist, long-acting muscarinic antagonist. And so this would be a COPD drug, this would be asthma or COPD, and a long-acting muscarinic antagonist, long-acting beta agonist, this would be the COPD drug. So for a patient with COPD, many of them can probably be managed exclusively with this device. So this is their rescue medication, Combivent, and then this is their controller medication. So that has some attractiveness as far as patients only needing to learn how to use one type of device well.
So there is no inspiratory technique specific flow rates and stuff like you have with an MDI?
So here is the technique. But patient is encouraged to breathe in slowly, so that would be similar to a meter dose inhaler, but be similar to a nebulizer as well, right?
Sure.
So this is the technique. So you turn the base, and that's what pressurizes the spring, and then you open the mouthpiece. So it's important not to open the mouthpiece first. So this is the mistake that I made when I first learned about this device. I was actually demonstrating in front of a group, and they all laughed because every time I would turn the base, I would open the cap and then turn the base, and I would be holding it with my thumb
And
over,
shoot out in the atmosphere.
right, with my thumb over the button, and I turn the base and I'll shoot out. So the mouthpiece has to remain closed. You turn the base, you then open the mouthpiece, put it in your mouth, start to breathe in, press the button. So I think overall relatively easy to use. They are expensive. I don't know what the cost is, but they are expensive. Okay, meter dose inhalers. So Bob had asked, well, how much of the drug actually gets into the lungs? And I said 10 to 20%, and some of it goes out into the room, some of it stays in the nebulizer cup. With a meter dose inhaler, still only about 10 to 20% gets into the lungs with good technique. Where does the rest of it go?
Well,
In your throat or in the spacer or valve holding chamber.
Oh, okay, so it's the same even with the spacer.
It's the same with the spacer.
Oh,
So
okay.
all the spacer does, or the valve holding chamber, is it takes the 80 or 90% that would have gotten deposited in the pharynx, and now it gets deposited in the device, if the patient has good technique. Now, if the patient has poor technique, the delivered dose can approach zero, can be zero. The patient's flowing out while they actuate the device, the delivered dose would be 0. So their valve holding chamber would improve the amount delivered to the patient. So in a patient who has good technique, what the spacer or valve holding chamber does is it just changes the site of the deposition of most of the dose. Now why then is that important? So it's a problem if you're doing inhaled steroids because you don't want 80% of it in the pharynx because then the patient gets thrush infections and so forth. With an inhaled bronchodilator, it might not matter that much. And in fact, as I will show a few slides down the way, in a patient who is using an albuterol inhaler, who has good technique with the albuterol inhaler, there's no reason to add a spacer, just adds cost and complexity. And patients aren't going to carry it with them anyway. So we tell them to keep their controller medication with them, and they're not going to carry, in their pocket this,
And the space is very good if you're giving it by mass to a child.
Correct, yeah, because that's right. So this talk is focused mostly to adults, but you are absolutely correct. So if you use a mask, the mask has a valve, and you hold the mask over the nose and mouth for, I think it's recommended 6 breaths, and then they evacuate the aerosol from the device and breathe out through the valve. So about 10 years ago now, or longer, 11 years ago, the propellants that were in meter dose inhalers, which were CFCs, freons, chlorofluorocarbons, were eliminated. They were outlawed by the FDA. Could probably bring them back now. That was a political statement. So.
You're probably right.
The current administration would probably be okay with it. At any rate, so all of the inhalers had to be retooled and reformulated by manufacturers to eliminate the CFC. So the problem was they had to come up with another propellant. What they came up with was HFA, or hydrofluoroalkane, and it wasn't just as simple as taking out the CFC and putting in the HFA. So that resulted in the meter dose inhalers being retooled so that they were repatented, so that a $10 meter dose inhaler now costs $300. And then the other thing is some meter dose inhalers, like Condivent, just went away. So the manufacturer said, we're not going to deal with this. And what they did was they came up with the Respimat instead. So one of the big issues, so 2 issues with HFAs is, first of all, clogging of the actuator is a problem. I'll talk about that, I think, on the next slide. And secondly, the high cost. But now, as I already pointed out, these devices the patents are expiring and generics are beginning to come on the market. There is now a generic albuterol that is supposed to cost around $300, $30, which is significantly lower than the brand name devices. And I tried to find out yesterday and could not. I don't know if it's yet available in pharmacies, but it will be any day. So these devices now need to be cleaned, so they can be cleaned. Most of them can be cleaned just by running warm water through the device and letting it completely dry before putting the canister back into the device. And it's recommended to do that periodically. And for the Advair device, it's recommended, this is right out of the package insert, to use a Q-tip and to clear the device. In fact, it can significantly reduce the amount of drug delivered to the patient by not doing that. This is one of those things that I suspect a lot of patients probably don't know that they should do. Dose counting is important. You cannot tell how much is in the device by shaking it next to your ear. You cannot tell how much is in the device by putting it in a can of water to see if it floats or not. The only way to tell is to keep track of the doses, and all new meter dose inhalers coming onto the market now have dose counters incorporated into them. There are third-party providers of things like the doser, which you, for additional money, can put on your meter dose inhaler that keeps track of the doses. But now that I think almost all of these have dose counters built into them, the market for this must be gone away. I don't think it was very big to begin with because I don't think it was ever covered by Medicare or insurance. Something else that is important to appreciate is that meter dose inhalers should be primed if they're brand new coming out of the box, or if they have not been used for several days, like the patient with asthma who uses albuterol as a rescue and they haven't used their inhaler for the last 2 weeks and now they need it, needs to be primed by shaking it and spraying several doses into the air, away from them, not into their face or their eye, but away from them. And the priming requirements are different for different devices. So some it's 1, some it's 2, some it's 3, some it's 4 actuations. But the important thing is to appreciate if you're using an albuterol inhaler, if it's brand new or if it has not been used for 2 weeks, that it needs to be primed with 4 actuations. Somebody asked me one time when I was doing a lecture like this, well, does the manufacturer put extra into the canister to account for that? The answer is
So would
no.
you explain why it needs to be primed? What happens?
It needs to be primed because inside the meter dose inhaler, the metering chamber, so here is the metering chamber. So when you shake it, that's what loads up the metering chamber, and if the meter dose inhaler is just laying on a countertop or carried around in somebody's purse or pocket for a couple of weeks, the drug that was in that metering chamber leaks out. So then all you get for the first couple of actuations is propellant until the metering chamber reloads. Is that what you were asking? Yeah, some people have recommended that the inhaler always be stored upright, but some of those kinds of things.
Ain't never going to happen.
It's not practical.
Right.
Okay, so you all, I'm sure, know the technique for using a pressurized meter dose inhaler. So it needs to be shaken, needs to be primed, which is what we were just talking about. Canister needs to be pressed at the beginning of inhalation. Slow inhalation, as Bob had asked about a little bit ago, breath hold. And the breath hold actually is the same, whether it is a Respimat device, a pressurized meter dose inhaler, or a dry powder inhaler, as we'll talk about in a few minutes. So here is a new one. I just learned about this within the last month. I think it's been on the market since probably earlier this year. This is a breath-actuated meter dose inhaler. The only drug in the United States that it's available with is Qvar, which is beclomethasone, inhaled steroid. In Europe, it's also available as albuterol. So I think it'll be a matter of time until it's available here also as albuterol. So some of us remember the autohaler from years past, which was a breath-actuated device. That device went away with the transition to HFA. The manufacturer wasn't going to reformulate it as an HFA. So here is a breath-actuated meter dose inhaler, so that gets around the issue of hand-breath coordination. However, and it does not need to, it should not be shaked or primed, so you don't have to remember to do that step. However, it cannot be used with a spacer or a valve cooling chamber. So that is a problem with an inhaled steroid, because then the patient breathes in, actuates, blows 80 or 90% onto the patient's pharynx, and then that can result in systemic side effects by what's swallowed and in a thrush infection in your pharynx if the patient's not very vigilant about rinsing and cleaning or brushing.
I understand why no spacer, but why why not shake and prime?
Yeah.
Yeah, so I think it's part of the engineering of the device, so that's.
That it just loads properly.
Yeah. So that I think is a good thing.
I agree.
But not being able to use it with the spacer or valve holding chamber is a problem, perhaps. And it does have a counter, a dose counter. So there's a breath actuated meter dose inhaler now that's back on the market. Okay, so what about spacers and holding chambers? So here's a spacer. Put space between the meter dose inhaler and the patient's mouth so that when the device is actuated, a lot of the dose gets deposited in the spacer instead of getting deposited in the patient's oropharynx. Valved holding chambers have valves that are designed to hold the dose until the patient inhales. So a valved holding chamber will be useful as a spacer, but will also be useful as far as improving hand-breath coordination. The spacer does nothing to address issues with hand-breath coordination. So if the patient blows out into a spacer, the drug's gone. With a valved holding chamber, because of the valves, it's impossible to blow back into the device. And then there are reverse flow devices which also minimize the amount of drug that is lost. So ideally then we should either be using a reverse flow device or a valve holding chamber. And one of my pet peeves is when we call them all spacers, because technically they're not all spacers. So a couple of things to appreciate about valve holding chambers. One of them is that we should only place one actuation of drug into the spacer at a time. So the more actuations that we place into the spacer at one time, the less drug that the patient gets. So if the patient has a prescription for 2 puffs from the meter dose inhaler, they shouldn't put both puffs into the spacer at one time. That reduces the amount of drug delivered.
Why?
And, pardon?
Why?
Because there's more of the drug that adheres to the sides of the device. And that is perfect. That is definitely the case if there is a delay between actuation and inhalation of the drug. So even with a 10-second delay, there's a significant reduction in the amount of drug delivered. So I think some people are of the perception that you can have the valve holding chamber and the meter dose inhaler out on the table and you can actuate the drug and then you can lift it up to your mouth and then you can breathe out and then breathe in. You're going to lose a lot of drug. So ideally, the mouthpiece of the device should be in the patient's mouth. They should initiate inhalation and actuate the device. The electrostatic charge. So our crowd is now down to 60% of what we started with. Decreased by 40%. So the electrostatic charge is an issue with valve holding chambers, which means that because of the electrostatic charge, there's a tendency for the aerosol to adhere to the inside of the device, and less of it gets delivered to the patient. So to get around the issue of electrostatic charge, probably the easiest thing to do is to wash the device in soapy water, rinse it, and allow it to air dry. So that will dissipate a lot of the static. The other thing you can do is you can prime the chamber with 20 actuations, but that's 10% of your meter dose inhaler. So you're going to run out of drug on the 20th day of the month. And then there are now commercially available non-electrostatic chargers, non-electrostatic charge chambers from several manufacturers. That improves drug delivery, but they are significantly more expensive. So the thing that I think we should be teaching our patients is you get a new valve holding chamber or a new spacer, just wash it in soapy water, rinse it before using it for the first time. Otherwise, the first couple times you use it, you're going to be coating the drug on the inside of the device rather than delivering it.
Should you wash it ever again?
That's a good question. I think it's controversial, and I don't know what the manufacturer recommends. To me, it seems like it would be a matter of good hygiene to periodically wash it. But every time that you wash it, the more that is coated with drug, the more that the patient's going to get. So then this is the question that I addressed a little bit before. Does every patient need a valve holding chamber? Well, I think not for reliever medications like albuterol if the patient has good technique. So if the patient has good technique with their meter dose inhaler that they carry around with them everywhere they go, there's really no good reason to add a spacer. It's additional cost. Patients aren't going to carry that around with them everywhere they go anyway. However, for inhaled corticosteroids, I think it's important to always use a spacer or a valve holding chamber to reduce the amount of oropharyngeal deposition and systemic effects due to swallowing. Now, this is probably, I suspect this is not a big problem for most patients because they're inhaled corticosteroids they take once or twice a day. So then they can leave their spacer at home and they can take their rescue medication, the reliever medication, with them when they're out and about. And the valve holding chamber does add some cost to the cost of the already expensive drug. So I think what I will do, this is probably a good place to stop before more of you decide to leave. And as Bob asked before we got started, will we be able to get even more lectures out of this? I guess we will, because there's a fair amount that we can still cover as far as dry powder inhalers, because there are a number of new ones that have come out recently. And then in the end, I wanted to talk a little bit about how do you select the right device for the patient, and I also wanted to talk about which drugs we use for COPD and which drugs we use for asthma, because I think that's a source of some confusion for some people, because the drug selections, some of the drug selections are the same, some of them are actually quite different.
So the advantage of inhaled drugs, one of the main advantage, you get effect to the target organ without systemic.
Yes, so that is the traditional teaching, and that is correct. Although the other thing that is part of this lecture that I can go over the next time is now there are drugs that are coming out for inhalation that are specifically intended to be delivered to the bloodstream. So inhaled insulin, inhaled methodopa, as levo, I keep saying that wrong. Inhaled levodopa is now available for patients with Parkinson's that I have a slide about later on in a presentation. So the traditional teaching that I learned in RT school and that I taught for many years is we use inhaled drugs because the effect goes to the lungs and it stays in the lungs. And that is important for respiratory drugs. But increasingly, there are drugs that are coming out whose intent is you don't want to keep it in the lungs. You want it to be absorbed so it has a systemic effect. So the argument is for convenience. So inhaled insulin,
that's all it is.
avoid
I was
it. So inhaled methodopa, inhaled levodopa. I'll eventually learn how to say that. But inhaled levodopa, it's convenient. So if you inhale it, it's a dry powder. It gets absorbed almost instantaneously. It has the effect almost instantaneously, and you don't have to take a pill and wait for it to work and so forth. To tobramycin. More about amikacin, I think, on the next slide, and it's not in your handouts because it's a brand new drug that was just released. Estrianam or Caistin can be used, so that's used 3 times a day with the Altera mesh nebulizer. That's what that looks like. I saw that there was one on Puris's desk earlier, so if you don't know what that looks like, stop by and Puris can show you one. What about antibiotics for VAP? Whole lot of question marks about that. What I can tell you was that there was a very large, like thousands of patients, very large, multi-center, multi-country study looking at the use of inhaled amikacin in patients with gram-negative ventilator-associated pneumonias, and it did not work. The study was stopped. After millions of dollars of investment, the study was stopped about a year ago. So there are lots of questions about antibiotics for VAP. There are strong advocates who use them a lot. There are others who advocate very strongly that they should not be used. So I think that it's sort of clear where they stand. Not good evidence, I think, one way or the other, maybe. Amphotericin B lipid complex, or Abelset, is used in the prophylaxis of aspergillus following lung transplant. They're still using that. I know they were using that when I was around all the time. Ribavirin for severe RSV infection. Do you still have those battles from time to time? Or is that
No,
gone
we were
away?
talking about that. We can't remember the last time
Yeah,
we actually
yeah.
used it. It's got to be 4 or 5 years ago.
I heard from someone, and maybe you know, that the company ICN is not even making the spags anymore. I don't know if that's true or not.
But
Somebody
don't know that.
told me that on my travels. And then
We wanted to throw away all of our stuff, but
You
we're
never know.
afraid that once we throw it away, we'll get an order.
Yeah, you may not be able to get replacement parts. I had heard that they don't make it anymore, so,
Well, that tells you its efficacy.
yeah. Well, and that it can be administered orally, and there are other ways.
Well, yeah, but by aerosol.
Yeah, than by aerosol. And then pentamidine, administered by the Respigard 2 nebulizer, can be used for prophylaxis of pneumocystis, what we used to call pneumocystis carini, administered once a month. There are better oral drugs, like Bactrim is what is typically used now for that. But there are some patients who can't take Bactrim and still take pentamidine, but it's very few.
Yeah, but
We get maybe 2 a year
I was going to say, I don't remember. We do get some orders for it.
occasionally.
It's usually done on an outpatient basis.
Yeah, they do
you know,
it in
at yeah.
They can go to the Cox 2, PF2.
But back in the mid-1980s, and Bob knows about this, back in the mid-1980s, during the HIV epidemic stuff, there were respiratory departments who had clinics where therapists just did pentamidine treatments essentially all day long, you know. So,
And there were numerous case studies of therapists having significant pulmonary issues as a result of
yeah, so that's
delivering.
So that's the reason why the device, for example, has valves and filters and so forth to try to decrease
That chronic exposure is
the
not
chronic
good.
exposure. Yeah. So this is the new one, and then maybe we'll stop after this one, and I've got material for the next talk already prepared. So this is the latest one to be approved by the FDA. So this is amikacin liposome inhalation suspension. And so this is amikacin. It is used for specifically to treat, difficult to treat, MAC infection, Mycobacterium avium complex. So, I don't know, if you might do sputum and find out that the patient has MAC, and then you might be doing an aerosol treatment to treat that. This again is approved only to be used with this mesh nebulizer. So this device was approved specifically to be used with this drug.
Is it
and
the
it's-
same?
Pardon?
Is it the same one as
So it is basically the same one as for Caiston. What I don't know is whether the mesh, so this is a mesh nebulizer, I think that the mesh is specific for each of the drugs.
It's a little different. So
So-
I don't think, Caiston is not on our formulary.
It's not. It comes from a
And I doubt
specialty
that this
pharmacy.
is on our formulary.
Correct. So the way that this is available and the way Caiston is available is patients And this will, I think, be used primarily in CF as well. But patients get from a specialty pharmacy a 28-day supply. So they get a box. If you ever saw what comes with Caseton, there is a box that is about this big, and inside that box is the nebulizer and 28 days worth of the drug. And so every 28 days, so end of 28 days, use up all the medication, throw it away, and then get a new box. And this, I'm sure, will be the same way. Yeah, this is not something, your point's a good one, this is not something that is going to be on the formularies probably of any acute care hospital.
Correct.
And it needs to
Because
come,
it costs a fortune.
and it costs a fortune, it needs to come from a specialty pharmacy. So you can't go to CVS and get it either.
And it'll probably end up to be the same thing. We'll see it in select cystic fibrosis patients.
So this is reserved to be used in patients who have MAC unresponsive to conventional therapy.
Treatment, right.
So it will be a very rare use. Okay, so we will stop. And the next
So
time we
before
will
you
talk
stop,
about vasodilators.
give us a couple comments about tranexamic acid.